Let's talk about something that might not seem as dramatic as a code blue, but can sneak up on your patients fast: fluid imbalances. We're going to walk through fluid volume deficit first, then fluid volume excess. And I promise you, by the end of this, you'll be able to picture exactly what's happening inside the body and know what to do about it. Fluid volume deficit. Medical management. When we're correcting fluid volume deficit, or FVD, the provider doesn't just grab the nearest IV bag and hook it up. They look at the patient's maintenance needs and other factors that affect fluid requirements, like fever, because fever alone can raise fluid needs significantly. If the deficit is mild and the patient can swallow safely, we go oral first. No reason to start a line if we can get them to drink. But if that deficit is acute or severe, think low blood pressure, tachycardia, delayed cap refill, we're going straight to IV fluids. And our first-line choice for the hypotensive patient is almost always an isotonic electrolyte crystalloid. That means lactated ringers, 0.9% sodium chloride, normal saline. These expand plasma volume quickly. Once the patient's blood pressure stabilizes, once they're normotensive, we can switch to a hypotonic electrolyte solution like 0.45% sodium chloride. That's going to give them both electrolytes and water, which helps the kidneys excrete metabolic waste. Now, this isn't a hang the bag and walk away situation. We're checking intake and output, down to the mLs, daily weight, same time every day, same scale. Vital signs, central venous pressure if they have a line. Level of consciousness, breath sounds, because the last thing we want is fluid overload. Skin color. The speed of fluid replacement depends on how bad the loss is and how the patient responds. When urine output is low, the fluid challenge. If our patient with severe FVD isn't putting out enough urine, they're oliguric, we have to figure out why. Is it pre-renal azotemia? That's when poor renal blood flow from FVD reduces filtration. Or is it intrarenal azotemia from acute tubular necrosis because the kidneys have been underperfused for too long? That's where the fluid challenge test comes in. Here's how it works. We give 100 to 200 milliliters of normal saline over 15 minutes. Not too much, not too little. While we're infusing, we're watching everything: vital signs, breath sounds, orientation, CVP, urine output. If the patient's kidneys are healthy and the problem was just low perfusion, you'll see urine output go up, blood pressure improve, CVP rise. If none of that happens, we might be looking at an intrinsic kidney injury. When deficit turns into shock. Here's the scary part. If a patient loses more than 25% of their intravascular volume or loses it fast, they can go into shock. We'll cover shock in more detail in Chapter 11. But remember, in fluid loss this severe, you're in a race against tissue hypoxia. Fluid volume excess, hypervolemia. On the flip side, we've got fluid volume excess, or hypervolemia, which is basically the expansion of extracellular fluid because the body is holding onto sodium and water in normal proportions. The most common reason? An increase in total body sodium, which pulls water right along with it. Pathophysiology. Hypervolemia can be caused by simple fluid overload, heart failure, kidney dysfunction, cirrhosis, too much sodium in the diet, too much sodium-containing IV fluid in a patient with poor regulatory function. Clinical signs. When that ECF expands, you'll see edema, ankles if they're up and walking, sacrum if they're bedbound, distended jugular veins, crackles in the lungs from interstitial pulmonary fluid. Diagnostics. In FVE, lab values shift. Bun and hematocrit drop because the plasma is diluted. Chronic kidney disease, you might see low serum osmolality and low sodium from water retention. Urine sodium goes up if the kidneys are trying to dump excess fluid. If aldosterone is chronically stimulated, like in cirrhosis, HF, nephrotic syndrome, urine sodium stays normal because the sodium's being reabsorbed. A chest x-ray might show pulmonary congestion. Detecting and controlling hypervolemia. The earlier we catch FVE, the easier it is to manage. Interventions include promoting rest. Bed rest helps diuresis by reducing venous pooling and improving renal perfusion. Restricting sodium and fluids as ordered. Monitoring diuretic response closely. Watching IV fluid rates carefully. Semi-Fowlers for dyspnea or orthopnea. Turning and repositioning often because edematous skin breaks down faster. We also teach patients to monitor their weight daily and keep track of I&O. Patient education. Edema. Edema is the big visual cue for FVE. We explain what's happening. It can come from increased capillary pressure, decreased oncotic pressure, or increased interstitial oncotic pressure. Sodium retention is a frequent cause. Burns, infections, lymphatic obstruction, low albumin, and heart failure can all play a role. Types of edema. Localized, like ankle swelling and arthritis. Generalized, like an HF or kidney injury. Severe generalized equals anasarca. Ascites, fluid in the peritoneal cavity. Often from HF, cirrhosis, nephrotic syndrome, or tumors can cause shortness of breath from pressure on the diaphragm. Medication review. We check for drugs that cause or worsen edema. NSAIDs, estrogens, corticosteroids, some antihypertensives. Treatment goals and options. Our goal is to preserve or restore circulating volume. That means treat the cause, use diuretics, restrict sodium and fluids, elevate extremities, apply anti-embolic stockings, perform paracentesis for ascites when needed. In severe or kidney-related cases, use dialysis or continuous renal replacement therapy. Key takeaways. FVD needs prompt replacement. Start oral if possible. I4 if severe. Monitor closely for improvement or signs of overload. Use the fluid challenge test to evaluate renal response in oliguric patients. FVE often comes from sodium and water retention. Think heart failure, kidney dysfunction, or cirrhosis. Early detection prevents complications. Watch for edema, weight gain, lung sounds. Education is key. Patients should understand their symptoms and treatment plan. If you understand these fluid shifts, you'll not only recognize the signs early, you'll know exactly what levers to pull to get your patient back into balance before either deficit or excess tips them into crisis.